introduction. So mainly part of it will be about myocarditis too. So immune checkpoint inhibitors. I have no disclosure. So basically, these immune checkpoint inhibitors management and treatment of cancer actually has changed the landscape of cancer treatment. So the basic principle is that we activate host immunity to regulate cancer growth, meaning to basically to eliminate cancer growth. And this is based on the hypothesis that the immune system is capable of detecting and eliminating cancer cells. And the success of immunotherapy is reliant always on the tumor immunogenicity, depending on the tumor antigen expression, tumor infiltrating cytotoxin CD8, and other tumor microenvironment. And basically, the Nobel Prize for all this discovery of ICI goes back to James Allison and Tasuku Hongo, physiology and immunology professors, for this innovation. So immune checkpoints are proteins expressed in the T cell that inhibit their activation when they contact a body cell. And these immune checkpoint inhibitors, they include monoclonal antibodies that block the immune brakes or regulators like the cytotoxic T lymphocytes, the programmed death one, and the ligands of the programmed death one. So when we block these expression of the checkpoints, we activate the T cell and thus promote killing of cancer cells. There are 4 immune checkpoints that usually are targeted in immune checkpoint inhibitors. Cytotoxic T lymphocyte associated antigen 4, and there are a couple of them. Programmed death 1 and programmed death 1 ligand, PD-L1 and PD-1, and lymphocyte activation genes. And all these are approved by USA, FDA for use in anti-cancer therapy, either as monotherapy or in combination with other ICIs or in combination with other chemotherapy. This is just a summary of the immune checkpoint inhibitors that block the T cell activation. Like the PD-1, there are multiple of them, like nivolumab, pembrolizumab, etc. PD-L1 ligands like avelumab, durvalumab. You can hear them more and more if you are encountering patients with cardio-oncology or oncology patients. CTLA4 like ipilimumab and others. So these can be used as combination, or they can be used as single agent. Indications are rapidly broadening across various cancer types, to cure patients as palliative therapy as well as adjuvant therapy. Almost half of all patients with metastatic cancer in high-income countries are being treated with ICI. But they have always the immune-related adverse event due to excessive immune activation. Just this is from 2022, you can see how many indications for immune checkpoint inhibitors, and this has been growing progressively every year. FDA approves more and more immune checkpoint inhibitors indication. All these are given intravenously. The most commonly used are the PD-1 and PD-L1 inhibitors, either monotherapy or, like I told you, as combination therapy. These are the immune-related adverse events of these. They affect the brain, the eyes, the lungs, the liver, the muscles, as well as the GI tract, as well as the heart in these conditions. Skin is mostly affected in 71% of the patients. The heart conditions are the least affected. These are the direct and indirect cardiovascular toxicities: arrhythmias, myocarditis, non-inflammatory heart failure, tachycardia or stress-induced cardiomyopathy, pericarditis, and other like vasculitis, and indirectly through thyroid disease, adrenal thyroiditis that can cause tachycardia, etc., or any metabolic derangement. This is a recent study just published recently, which is a French National Health Data Registry. They collected all the patients with ICI adult treated with around 172,000 patients. The incidence at 6 months of myocarditis and myositis was around 0.7 to 0.9%. What's important, the major risk factors are thymic and skin cancer, history of thymic disorder or myasthenia gravis, ICI combination when they are in combination, and elderly patients above 85. ICI-induced myocarditis and myositis have shown that they have poor prognosis or reduction in survival in these patients. So what are the conditions related with high baseline ICI-related cardiovascular toxicity? To start with dual, like ipilimumab and nivolumab, which is mostly commonly used, combination with other cardiotoxic therapies, chemotherapies, and patients who already have prior events of chemotherapy-related cardiac dysfunction or cardiovascular disorders. These are the cardiovascular toxicities. If related to overactivation of inflammation are myocarditis, pericarditis, vasculitis, but it can also activate increase in dyslipidemia, progression of atherosclerosis and acute coronary syndrome, in addition to non-inflammatory progression of heart failure and arrhythmias. But there is what is called an overlap syndrome in around 0.1% in these patients, where you have myasthenia gravis, myositis, and myocarditis at the same time that it occur. And this actually is a highly mortal, with a mortality rate reaching up to 60% if they occur. So whenever we are suspicious, we have to screen for all these three. This is the definition of myocarditis by the cardio-oncology definition guidelines. So there is an elevation of troponin above baseline with one major criteria like cardiac MRI diagnostic for acute myocarditis, or two minor criteria including clinical syndrome like fatigue, myalgias, chest pain, etc., ventricular arrhythmias, decline in LV function, or suggestive of MRI, suggestive of myocarditis. Severity of myocarditis can be fulminant or non-fulminant. And the recovery from myocarditis, there are some definitions. Recovery where they are recovered with no symptoms and they may still have some LGE on cardiac MRI, and recovering where they improve their symptoms, hemodynamically improve, but still they are not fully recovered. Usually when we suspect an immune-related adverse effects, we have to evaluate for any other alternative cause, and we have to grade them from grade 1 to grade 5. Usually mild asymptomatic or mild symptoms is grade 1. Moderate is limiting age-appropriate activities, etc. And the grade 5 is the death-related adverse event. And the grade 4 is life-threatening that needs intervention. Usually grade 1, we need to continue ICI therapy with close monitoring. Grade 2, we have to consider in a MDT meeting to consider withholding and considering steroids in these patients. Grade 3, we have to withhold, treat with steroids, and consider other immunosuppressive agents and supportive treatment. While grade 4, we have to permanently discontinue ICI in these patients, and we have to refer to the other subspecialties. Usually at baseline, we have to take an EKG, echocardiography, troponin, and anti-proBNP, and we have to follow up these patients depending on the risk. High-risk patients, we have to follow up very frequently. One note to tell you that myocarditis and adverse events occur mainly in the first 3 months, then the chance is less likely to occur, especially the inflammatory adverse events. When it is ICI-related myocarditis, we have to check the severity if it's fulminant or non-fulminant. We have to discontinue ICI, admit the patient with EKG monitoring, and we have to load him with methylprednisolone, 500 to 1,000 IV bolus, once daily, at least for minimum 3 days. Re-evaluate. If the patient is recovering, we can shift to oral steroids and wean gradually for complete recovery. If steroids refractory, we have to go to second-line immunosuppression. And if hemodynamically unstable fulminant myocarditis, we have to go with the guidelines of mechanical circulatory supports in addition to second-line immunosuppression. Second-line immunosuppression, there is no one recommended immunosuppressive agent, but we can use IV mycophenolate, anti-thymocytoglobulin, immunoglobulin, and others like abatacept and CTL4 agonists, etc. Other complication other than myocarditis in acute coronary syndrome, and we treat it accordingly. We stop the ICI and treat it with the dual antiplatelet, beta blockers, high-dose statin. And the last is new onset arrhythmia. We have to discontinue ICI, admit the patient, consult cardio-oncology, investigate for myocarditis by cardiac MRI, investigate for coronary angiography, and think if the need of endomyocardial biopsy, especially in very critical patients, and treat according to the cardiac disorders, treat arrhythmias as well as treat by pacing and treat VT or VFAB by rate control. Can you show me the last slide, please? I am on time. Last slide is the take-home messages. ICI indication is expanding. Immune adverse related events are common. Non-cardiovascular are more than cardiovascular adverse events. Myocarditis is not the only cardiovascular adverse events, but most fatal. Early recognition and treatment is life-saving. Low suspicion is very important, but more data are evolving regarding the treatment and follow-up. Thank you.